Yes, ma'am, we are live.
Okay. Should we wait for some time?
Yeah, shall we start?
Um,
Shall we proceed?
yeah,
Yes,
ma'am. It's fine
Nirvala.
from my side.
Yeah. Very good evening, all the delegates. On behalf of BSV, I welcome you all for the today's session. The topic for today's session is aplastic anemia, a comprehensive approach. And today we have with us Dr. Madhura Deshpande. She is a BMT physician at Bharti Hospital, Pune. Welcome, ma'am, for the today's session. And without any delay, I hand over the session to you.
Yeah. Thank you so much, ma'am, and thank you, BSV team, for enabling us on this virtual platform. So we'll just. This is the disclaimer. So, talking about the epidemiology of the disease, aplastic anemia, the incidence varies between the Western world and in the Asian countries, where we see much higher incidence and prevalence in Asian countries. And there is no gender bias. However, we do see biphasic age distribution with one peak seen in the teenage group and the second one in the geriatric population or the older adults, above 60 years. So, in the developing countries, these are the we can see the diagrams, the values for the severe, very severe, and non-severe aplastic cases, and we can see the predominance of non-severe aplastic anemia. This is we will see how these types of aplastic anemia are classified as per the Comita classification in a while. But on the left side, we can see that the incidence and mortality both increase with age, which is likely possible because of the age-related additional risk factors. Okay. So speaking of the genetic correlation, nowadays we are moving more and more towards identifying relevant molecular biomarkers and establishing their role in not just diagnostic areas but also to prognosticate and to have targeted therapies. So in the therapeutic part also we are relying heavily on the genetic background that comes with these diseases. And if we can see in the chart on the left side, we can see the frequency of the genetic mutations seen in different types of bone marrow failures. So DNMT3 and ASXL1, which are the commonest methylating genes mutated, they are seen in MDS, aplastic anemia, and age-associated clonal hematopoiesis, also called as ARCH. And PIG-A, BCOR, and BCOR1 are commonly mutated in aplastic anemia, but they are not that frequently noticed in MDS. So there is predominance of certain genetic mutations in aplastic anemia as against other diseases. And as the age advances, patients are more likely to have more and more number of mutations. So this is the etiology of the aplastic anemia. We can see that it's believed that aplastic anemia is an autoimmune mediated attack on the host stem cells. So the cytotoxic T cells in the host are in turn activated against host hematopoietic stem cells, leading to the stem cell damage and thus pancytopenia, which is the hallmark feature of aplastic anemia. So it can be antibody induced, it can be seen in GVHD, post-transplant, SLE, eosinophilic fasciitis. Many chemicals are notorious to lead to different kind of hematological disorders such as aplastic anemia and many agents. So we see commonly in oncology ward that people who were treated for different types of oncological malignancies, they later on develop aplastic anemia as a side effect of these drugs. Then hereditary causes we must not forget, and they can have a delayed presentation as well. Infections, many a times in pediatric or adolescent age group, we do see post hepatitis patients developing aplastic anemia. And then there are other causes such as radiation, hypopituitarism, PNH, pregnancy, thymoma are also well described risk factors for aplastic anemia. So there are a wide variety of risk factors, and as we are going to advance, this list is just going to, get bigger and broader. But seldom does it have any therapeutic significance. So etiology-wise, the four main subgroups are idiopathic, wherein majority of our patients fall into this category because we may not be able to give them a reason as to why they developed this in the first place. Some drugs, infections, pregnancy, autoimmune disorders are commonly seen. So here we can see a list of the drugs which do cause some or the other type of marrow damage leading to aplastic anemia. And the symptoms which are seen in aplastic anemia are related to the type of deficiency it produces, such as anemia leading to fatigability, pediledema, symptoms of cardiac failure, thrombocytopenia leading to petechial or purpuric rashes, mucocutaneous bleeding tendencies, epistaxis, menorrhagia, and recurrent infections, which can be mild, moderate to severe, needing hospitalization for such patients. So, this is a beautiful diagram, Venn diagram, showing how aplastic anemia overlaps with multiple other hematological disorders. So as to call the relationship of aplastic anemia with other diseases. So many a time we cannot separately look at aplastic anemia. It may be a evolving entity in patients who already have an underlying hematological problem such as AIHA or ITP or pure red cell aplasia that has over a period of time evolved into aplastic anemia. And PNH and MDS can coexist. In fact, PNH can precede, PNH can coexist, or aplastic anemics can develop into full-blown PNH picture. So the relationship is a multifaceted relationship between aplastic anemia and the PNH. We have to monitor PNH clone right from the diagnosis of aplastic anemia till the treatment, even post-treatment also we are supposed to monitor. And on the left side, we can see that these are the genetic biomarkers such as GATA2, RUNX1, CTLA4, and MPL. They kind of share the phenotypic presentation between PNH, aplastic anemia, and we must not forget the telomere diseases which are seen in the older adults and also in the younger adults with a high likelihood of family history. So MDS, aplastic anemia MDS phenotype can later progress into AML with poor prognosis given to the biomarkers that it inherits. So we must understand the relationship and the disease biology for better monitoring and better planning the treatment for these patients. So talking about the mechanisms of stem cell damage in aplastic anemia, so it can be a physical or chemical damage wherein the patients may have history of radiation exposure or exposure to chemotherapy, or it can be an immune mediated attack. Such patients do respond well with immunosuppressive therapy, and it can be a constitutional genetic defect wherein we may have to employ different strategies. The immunosuppressants may not work, may will not work in this situation. So the common pathology of the bone marrow replaced by the fat cells, adipocytes, it can be multifactorial. But depending upon the broader mechanism involved, we have to plan the subsequent treatment. So acquired aplastic anemia, which is one of the most common entity that we come across, being an adult hematologist, we seldom come across inherited causes of aplastic anemia with later presentations in the adulthood. So here we can see that this is a cytotoxic T lymphocyte and this is a hematopoietic stem cell. So it has these multiple receptors on its surface, and this cytotoxic T lymphocytes can secrete interleukin 2. Interleukin 2 is a T helper ligand which will call for more T cell to the site of action, leading to expansion of the auto-damaging T cell clones, ultimately leading to the apoptosis of the hematopoietic stem cell and further toxicity to the surrounding stem cell niche. So this is the basic pathophysiology, that is the damage to hematopoietic stem cell. To dive deep into the pathology, destruction of the bone marrow may occur through two mechanisms. One is activation of the FAST receptor by the FAST ligand present on the T lymphocytes, which is the apoptotic pathway or the programmed cell death pathway. And secondly, interferon gamma may affect immune destruction via interferon regulator factor 1 and induction of cellular genes such as INOS or the inducible nitric oxide synthase, which leads to the development of a cytotoxic environment conducive to the cell death. So either they induce the apoptosis or they inhibit progression of the cell cycle. Um, it involves the immunology of the aplastic anemia. Here in the flow chart, we can see beautifully that how the stem cell can genetically altered stem cell can express new antigens, thus leading to further immunogenicity, or it can lead to the reduced proliferative potential and differentiative capacity of the stem cell, ultimately leading to the marrow hypoplasia or aplasia. So it involves cellular as well as molecular pathways, and the T cells play a central role, whereby activating the activated by antigen presenting cells, and because of the increased availability of interleukin 2, there is a vast expansion of autotoxic T cells, leading to the eventual death of the hematopoietic stem cell. That is why it was corroborated to use immunosuppressive therapy in this plastic anemia category. So this was the Kamita criteria that I had earlier spoken about. So broadly speaking, aplastic anemia pathologically is classified into severe, very severe, and non-severe types. But for treatment or the clinical part, we only look at the two sides, whether the transfusion dependency of the patient and the risk for infections. So clinically speaking, we classify these patients into regularly transfusion dependent or episodically transfusion dependent. But putting that aside, pathologically, the severe aplastic anemia patients, they must have marrow cellularity of less than 25%, plus at least two of the following: ANC or the absolute neutrophil count less than 500 per cubic mm, platelet less than 20,000 per cubic mm, and retic count less than 20,000, which is now modified to less than 60,000 as assessed by the automated reticulocyte counters. Very severe is the rest of the classification stays the same, but the neutrophil count in very severe has to be less than 200 uh, cells per cubic mm. And non-severe aplastic anemia is the one that does not fulfill the criteria of very severe or severe aplastic anemia. These are the type of patients wherein we do not have to plan an emergent therapy, but we have to counsel them for the expectant outcomes. So the incidence of progression and mortality in moderate and severe aplastic anemia, we can see the curves are majorly different between the two sides. So the yellow line here is showing severe aplastic anemia, and the blue line here, the blue curve is that of a moderate aplastic anemia. So we can see that cumulative incidence of progression is much different with the significance of p-values in the two curves. And we can see the mortality, the incidence of progression to the AML, and the overall cumulative mortality as well. Speaking about the clinical features, symptoms are pertaining to the decreased bone marrow production of the blood cells. It is insidious in onset, and the initial symptoms, the most common symptom that brings the patient to the OPD is bleeding or petechial purpuric rash many a times. Anemia may manifest as anemia-related symptoms such as fatigability, swelling of the feet, palpitations, headache. Thrombocytopenia may lead to mucosal or gingival bleeding, and neutropenia may manifest as mild to moderate to severe infections. And not to forget the mucositis. So, is there a link between the two? Yes, definitely there is a link. So, depending on which type of the cell is predominantly involved, there are some patients who do not have as bad leukopenia as thrombocytopenia that they have. So it depends on which of the three cells has taken a toll in a particular patient, and likewise the patients present with related symptoms. So survival indices, differences in survival rates of moderate aplastic anemia and severe aplastic anemia. We can see the difference between the two. So the black box here is showing severe aplastic anemia. We can see as the time progresses in third year, we can see there is a gross difference. So nearly about 60% is the survival in moderate aplastic anemia as compared to some 22 to 23% at the third year in cases of severe aplastic anemia. Yes. Diagnosis and evaluation. So when the patient first presents with the diagnosis, or the patient is referred to a hematology OPD by a treating physician, we have to must ask the patient about the history of previous exposures that could explain the disease, the physical examination, not to miss out on any enlarged lymph nodes and splenomegaly, because then we must think about the alternative diagnosis. Laboratory investigations, apart from the obvious laboratory investigations, we have to conduct a battery of investigation to thoroughly plan the treatment, such as liver function test, because many a times we see post hepatitis aplastic anemia, especially in adolescent population, and these viruses are non-A, non-B, and non-C types. So such as say Epstein-Barr or Coxsackie, these are few examples of non-A, non-B, non-C viral hepatitis. Among others, then antinuclear antibody. So connective tissue disorders can rarely present as frank plastic anemia. So we must not forget to do an ANA and rheumatoid factor. PNH, it is an absolutely essential test to do at baseline and then to do it at successive monitoring if the baseline PNH clone is detected. So a small PNH clone is found in about half of the patients with aplastic anemia, and this is important to assess the progression of PNH. Pregnancy test, any young female patient, we must do a pregnancy test before we do any kind of immunosuppressive treatment. Serum copper levels, Fanconi anemia testing, telomere length testing, and additional mutation analysis. These are done in relevant settings wherein, suppose a patient is less than 40 years old, then we must rule out other causes, because if these causes are present, then the patient may not respond to immunosuppressive therapy. We may need to add in, um, you know, different biologic agents such as danazol, the androgens, or we may also have to give a short course of steroids. So this is a beautiful flow chart showing diagnostic procedures in pancytopenia, how we progress with bone marrow biopsy. The role of bone marrow aspirate and biopsy is to exclude hypoplastic MDS, MDS, metastatic cancer, and other conditions from aplastic anemia. Then on peripheral blood, we can conduct the DEB test, which is seldomly done now, but we can do a stress cytogenetics also. Then GPI negative cells is again assessing the PNH by FLAIR. We can do it by flow cytometry. There are other ways of testing the PNH, but nowadays we heavily rely on flow cytometric assessment. Exclude antibody mediated cytopenias because the treatment may be simpler than aplastic anemia here, and to determine telomere length. So, if we have arrived at a diagnosis of acquired aplastic anemia, then we must, in relevant settings, counsel the patients for bone marrow transplant. So, HLA typing is a must, and accordingly, we have to go for either IST or BMT treatment. So, we will see which patients to, counsel for bone marrow transplant. So this is a pictorial presentation between how a normocellular bone marrow looks like and how the aplastic. So you can see it is all replaced by the yellow fat here in the aplastic anemia. And this one normocellular marrow is looking reddish in color. And the slides also you can see the percentage of the fat cells. So a normal principle which is used while assessing the cellularity of the marrow is that 100 minus age gives the percentage cellularity of the bone marrow at that particular age. So a newborn baby's bone marrow will be 100% cellular, whereas a 90-year-old person will have 10% normal cellularity of the bone marrow. Anything less than that accounts for hypocellularity. And less than 25 to 30% of the expected cellularity accounts for the diagnosis of aplastic anemia among other diagnostic criteria. Yes. So, this is a very common step in any clinician's workup for any pancytopenic patient to have differential diagnosis. So, pancytopenia with hypocellular bone marrow is predominantly seen in acquired aplastic anemia, hyperplastic MDS, inherited aplastic anemia, and hypoplastic AML. Pancytopenia with cellular bone marrow can be seen in PNH, MDS, myelofibrosis, bone marrow lymphomas, megaloblastic deficiencies, brucellosis, sarcoidosis, hypersplenism. So that's why a thorough general examination is a must, because cases of hairy cell leukemia, hypersplenism, bone marrow lymphoma, or even vitamin B12 for that matter, will have certain amount of organomegaly, and if they may also additionally have icterus and other findings. So that's why thorough workup, thorough journal examination and history will help us pinpoint and narrow down our list of differential diagnosis. And hypocellular bone marrow without or with frank cytopenia can be seen in Q fever, hypothyroidism, TB, anorexia, mycobacterium, and Legionnaire's disease. So, a general approach to diagnosis and evaluation of the aplastic anemia. This table is taken from the article by Amy Dizern, who has done some pioneering work in use of ATG in aplastic anemia, and it's a recently published article in 2021. Not so recent, but yeah. So, patient with suspected diagnosis of aplastic anemia, so we have to carry out the normal charade of clinical and family history, standard laboratory workup, bone marrow study, and depending on the age of the patient and the fitness of the patient, if the patient is under 40, then we must not forget that certain inherited bone marrow failure defects do present at a variable age, and hence we must conduct chromosome breakage, lymphocyte telomere length measurement, and other relevant genetic evaluation, so to rule out inherited bone marrow failure diseases. Um, and if the patient is above 40, then depending upon the clinical features and other history, we have to plan whether the patient can pursue bone marrow transplant or an immunosuppressive therapy in case of lack of funds or lack of matched donor, or if the patient has been thought to progress rapidly to MDS-AML type. Okay. And so likewise, we have to progress. So the three modalities of treatment instituted are stem cell transplant, immunosuppressive therapy, and supportive care. Obviously, the choice of therapy depends on how bad the disease is, how badly symptomatic the patient is, how fit the patient is, whether the patient has any good number of HLA matched donors available, and in India, not to forget the availability of funds. So, there have been some studies that particularly say that the interval between the diagnosis and therapy has a significant influence on the prognosis, and this is believed to arise from the number of transfusions and transfusion-related damage, such as, say, iron overload or transmission of viral diseases, and many others. Okay, a sound tentative diagnosis should be reason enough to refer patients to a hematological center which has experience in the therapy of aplastic anemia. So let's look at the management scenarios in children less than 18 years and in adults less than 40 years. So see, if I'm treating a pediatric patient with aplastic anemia, I have two options. The first one, anywhere in the world, is going to be allogenic bone marrow transplantation. I can either use a matched sibling donor or match unrelated donor or a cord blood unit to carry out the same thing. If that is not available, then the next best choice is immunosuppressive therapy with or without L-thrombopac. And the response time on an average is from 3 to 6 months. So we do counsel our patients to be patient for a period of 4 to 6 months before we, counsel them for any other therapies. Um, and yes, long-term monitoring is needed in this setting to rule out evolution of the disease into, say, MDS, AML, and likewise. So in adults also, as we have seen earlier, depending upon the age and the availability of the donor, the treatment is majorly in two parts, carried out in two parts, the BMT and IST. And if we do come to a situation where the IST fails, then we must offer them urgent bone marrow transplantation. Because of the recent Baltimore Protocol, now the results of haploidentical bone marrow transplants in severe aplastics who have failed IST are increasingly good and very satisfactory. So again, this is the repetition of the same thing. The initial management, how we have to, if there is no matched sibling and the age is more than 40, then we have to use horse ATG plus cyclosporin. Um, and if there is no response, then we have to counsel him for alternatives. And non-HSCT options here are androgens, GCSF plus erythropoietin, supportive care, and there are some experimental protocols as well. Okay. So, how we have come to today, aplastic anemia management from say 20 to 21st centuries. So, so initially what we did was, so for less than 40 years, we had to look for a histocompatible sibling. If it was not available, um, then we would stuck with only the option of immunosuppressive therapies. But right now, because of the evolving horizon, now we can offer the options of matched unrelated transplants and haplotransplant for the same patient, which was a very difficult thing to plan in the late 20s. Yeah. Eltrombopag has been a game changer in the management of aplastic anemia since past 8 to 10 years, and we have had significant satisfactory responses to Eltrombopag alone in non-severe aplastic anemia patients, wherein just with the Eltrombopag alone, the patients achieve transfusion independence. And even in severe aplastic anemia patients, the results of IST have improved phenomenally with the addition of Eltrombopag. Yeah. The relative survival classified by the age. So 5-year survival for all patients has been around 65.4%, which is a very soothing number in Sweden. And relative 5-year old survival was 84.6% in younger patients and 45% in older patients. So these are the two tables here classified by the age. So we can see the impact of age in mortality of severe aplastic anemia patients. Yes, the same thing. Strong age effect after transplantation from an HLA identical sibling. So we can see the survival has improved from 55% to 86% for those patients who have had, matched related donor transplant. So first line trans. So it's a very satisfactory response. 86% is an excellent response rate. Best outcomes are seen for very young patients for whom first line and matched donor BMT may be considered. So yes, so sky is the limit now for newly diagnosed severe aplastic anemia patients. Nowadays, with the nuclear families, we have less and less donors available to screen from in the families, and hence we must focus on alternative donor strategies. And we are having some very good results from unrelated donor transplants for severe aplastic anemia. We can see the response rate is not so different, 86% from the previous slide to 85% in the current slide with unrelated donor transplants, which is not bad at all. And so the mechanism of ATG and cyclosporin. ATG, the mechanism we all know, is an anti-thymocyte globulin IgG mediated destruction of the T cells, and the cyclosporin is an mTOR inhibitor. So thereby reducing the expansion and differentiation of the cytotoxic T cells is the mechanism of cyclosporin, thereby reducing the damage and protecting stem cells from the cytokine storm in the bone marrow. Yeah. So because now we know the site of the attack, we can plan our armamentarium. So calcineurin inhibitors such as cyclosporin and tacrolimus and the depleting agents are ATG or ALG. Yeah. Yes. Yes. So, talking about survival rate for therapy comparison, there is no significant difference in survival in younger patients, whether primarily treated with IST or underwent with stem cell transplant. So this is what we need in Indian settings, because many of our patients cannot think about going for a bone marrow transplant whenever they are hit with a diagnosis of aplastic anemia. So if we have something as good as a triple IST with rates up to 88%, then that is something that we desperately need. And IST treatment, there have been no survival differences in the younger age groups, but in older age groups above 60, there is a significant difference between the survival rate with post BMT and post IST patients. That's a acceptable fact. So survival up to 10 years for severe aplastic anemia patients who were treated with ATG and CS as a first line treatment. So this was carried out between 1973 and 2007, and we can see that the survival rates are subsequently improving. So from 49%, they have gone up to 72 plus minus 6%, which is very satisfactory. Horse ATG, cyclosporin, and rapid ATG cyclosporin as first line therapy in severe aplastic anemia patients. So there have been certain studies conducted over a period of time with the usage of horse ATG and rapid ATG, and we can see phenomenal differences between the responses obtained via horse ATG and via rabbit ATG. So, except for two studies, others were prospective studies, and we can see that there is a significant difference proving the role of horse ATG unmatched in the treatment of severe aplastic anemia. So overall survival is 96% in the horse ATG group and 76% in the rabbit ATG group. And there is subsequent hematologic recovery in patients who are treated with horse ATG. And being in Pune, it's a proud moment for us because this is the land where horse ATG is manufactured. Our own Indian manufacturing unit is in Pune, and we are proud to be using thymogam for many of our patients, and we are happy that we are having similar outcomes in our patients. Yeah, so studies have confirmed better responses with horse ATG for obvious reasons. Um, so these are the different studies where they have reiterated the same fact that the horse ATG is in fact better than the rabbit ATG in this setting. Yeah. And the durability. So, talking about the durability of the responses after treatment with horse CTG, there is improved life expectancy and durable hematologic response, avoiding relapse of the disease and avoiding clonal evolution. So, approximately 50% probability of a first late event or relapse or clonal evolution among responders, we can see here in the graph, and high risk evolution to monosomy 7 complex karyotype high-grade myelodysplasia can occur in approximately 10% patients over a longer period. So we can see it has happened over 15 to 20 years of uh, span. So which is acceptable. Yeah. And so these are the different studies wherein they have analyzed the effects of ORCTG with cyclosporin. And at 6 months, 12 months, and 18 months, we can see there is successive recovery in some patients. Yeah. Other agents added to horse ATG. So they have time and again tried different agents such as say GCSF, danazol, mycophenolate, EPO, sirolimus, but they couldn't find any, satisfactory improvement in the outcome or in the clonal evolution or in the survival indices. So, yeah. Relapses post cyclosporin prolonged treatment after ATG. Median time to relapse for taper cohort was approximately 2 years, in contrast to 1 year when CSA was discontinued at 6 months. So, 40 to 50% of the relapses occurred within the first year when CSA when was discontinued after 6 months. Yes. Cyclophosphamide and severe aplastic. This was tried by Baltimore group, uh, but so this particular cyclophosphamide has had tremendous infective complications, and thus it is not, uh, accepted in the practice by hematologists globally. So initially, they had reported some good results with ATG cyclosporin 67 patients and response rate of 77% with a 10-year survival of whopping 88%. But when they added cyclophosphamide over ATG, they had a tremendously increased febrile neutropenia, and that's why it was not accepted as the therapy of choice outside of a clinical trial. Now, here comes the game changer molecule, the eltrombopag. So, combination of treatment for severe aplastic anemia improves responses by preventing the cytotoxic T lymphocyte mediated attack on the hematopoietic stem cells. That is the one part. And the second part is boosting stem cell function through thrombopoietin growth factor signaling. So this Trimurti works very well in severe aplastic patients, increasing the success rate like never before. And the responses have been seen to occur at earlier period, and the durability is also quite significant. So Eltrombopag added to the IST of ATG and CSA is acts as a springboard. This diagram correctly, depicts the role of Eltrombopag in the journey of a severe aplastic anemia patient. Yeah. So the mechanism. So it has a wide, multifaceted role in the severe aplastic anemia patients. It acts on the stem cell level by stimulating the HSCs and maintaining the HSCs. It promotes tolerance, so delays macrophage related activity. It increases the TREGs, which are the regulatory T cells, by thereby reducing inflammation in the bone marrow. Then it decreases interferon gamma, TNF alpha, TGF beta. We saw that these cytokines are actually mediating the stem cell damage. And then it also has a role on iron chelation by decreasing iron overload, which is considered to be toxic to the stem cell environment. Yeah. So wonderful results. So overall hematologic response is 88% for patients who were treated with Eltrombopag with IST, and 47% alone for patients using just Eltrombopag, which is not bad. So these are the hematologic responses seen in these particular patients. ATG and Eltrombopag. So higher survival rate of patients in the ATG plus Eltrombopag group versus ATG alone group for obvious reasons. Yes. And higher effective rate of ATG plus Eltrombopag versus ATG alone. So I think these are a few older slides because now we cannot think about ATG, aplastic anemia management without Eltrombopag, because this is a kind of an established guideline now. But in olden days, when Eltrombopag was not invented, this is what they were doing in 2019 and 11 and likewise. So this is an original NEGM article where they have mentioned about how the Eltrombopag addition led to phenomenal differences between the complete response rate at 6 months and median time to first progression. And the hematological complete responses at 3 months also had 50% difference between the Eltrombopag exposed and Eltrombopag naive patients. Yes. Hematologic and trilineage responses. We all know that Eltrombopag is not just a platelet molecule, but it has a trilineage effect, and that's why it has a special place in aplastic anemia, because it has a positive effect on all the three types of hematopoietic stem cells. And the trilineage response rates seen are to the tune of 34% and 74%. Yeah. Response rate was also higher than expected with standard immunosuppression. So 87% from 66%, which is a very good response rate. And 94% complete response rate were notably noticed in cohort 3. in which patients had the longest exposure to L-Trombopac. So here in cohort 3, they started L-Trombopac on day 1 itself, whereas in cohort 2, they had started it on day 14 and to 3 months, and in cohort 1, they had started L-Trombopac from day 14 to 6 months. So, this study tells us that addition of the L-Trombopag at the earliest and giving it for 6 months has the best possible outcomes in the treatment paradigm of severe aplastic anemia. So, diagnosis and management of adult aplastic anemia, the British Society of Hematology guidelines. So, basically, immunosuppressive therapy is indicated for all of those who are transfusion dependent and who are whose quality of life is affected because of the disease, and who do not have the age group or the fitness or the funds or the donor to go ahead with a bone marrow transplant. So ATG with CSA and Eltromobag is indicated in all of these settings. The dose of ATGAM or the horse ATG uh, ideally is recommended to be 40 mg per kg per day for 4 days, but it can be given over an extended period of 6 to 8 days also if the patient has experienced any allergic side effects, any immunologic phenomena are noticed, or a serum sickness that requires dose interruption has happened, or it can also be curtailed if there is any life-threatening infection in the patient. And we have to dilute each dose of ADGAM in 1 liter of sodium chloride 0.9%, and we have give the infusion slowly at a 5 ml per hour rate for the first hour of the infusion. We have strict orders not to start ATG outside of the working hours, office hours, because that is when all the senior faculties are available in the hospital. And we treat all our patients with antihistaminics and steroids from 1 day prior to the ATG exposure, so that to prime them for the um, immediate and delayed type of hypersensitivity reactions. So the ATG, EATG, that is Eltromobag ATG and cyclosporin in ATG intolerable patients. So in the patients where they did not tolerate ATG or had any drug limiting, dose limiting toxicities, they had treated these patients with just Eltrombopag and cyclosporin with um, reliable results. So we can see that between the proportion of patients with more than one period of red blood cell and platelet transfusion independence by 6 months. So in around 46% of the patients, the primary endpoint was met by 6 months. And almost two patients achieved a complete remission by 6 months. So even without ATG, there is a small subgroup of patient who has achieved complete remission. And but we have to keep in mind that all these patients who were showing good results without ATG were all younger patients, that is less than 65 years of age group. Yeah. And this is the SOAR study wherein the Eltrombopag and cyclosporine was beneficial for those patients who cannot receive treatment with ATG, or those patients with non-severe aplastic anemia for whom we may not plan ATG-based therapy with that much emergency as in case of severe aplastic anemia. And we have seen and experienced the practical feasibility of this Eltrombopag molecule, and it's mind-blowing how it works in this particular subset of patients. No, is just a very satisfactory thing to witness. Transfusion independence before and after Eltrombopag. Here we can see that in cohort A and cohort B patients. So cohort A are the ATG naive patients. They were given Eltrombopag because they had some or other ineligibility criteria for ATG. And in cohort B, 35 patients received Eltrombopag in the setting of refractory or relapsed disease, which is defined as the persistent transfusion dependency state at least 6 months after the treatment of ATG. So they have failed ATG. So cohort A is ATG naive and cohort B is ATG failed. And we can see that the transfusion um, independency was obtained in almost 56 and 49% of these patients, which is very good number. An increased hemoglobin level was seen in both the cohorts, and not only just hemoglobin, the neutrophil and platelet counts also improved significantly. So the addition of L-Trombopag in treatment-naive severe aplastic anemia patients. This is the pediatric study wherein the combined immunosuppression with or without L-Trombopag in children with newly diagnosed aplastic anemia. So initially, it was speculated whether eltrombopag is safe or not in pediatric age group, but then this particular study came in, and then it became a routine practice to add eltrombopag to standard immunosuppressive therapy in pediatric population as well, leading to extremely significant and good results, favorable outcomes in these patients in just 2 to 4 months of the time. Yeah. Again, in children, addition of eltrombopag to the standard IST did not improve outcomes in children with treatment-naive severe aplastic anemia. So, addition of eltrombopag alone in pediatric population should not be considered as the standard of care. But when it was given with IST, it did improve some outcomes. We have a couple of our patients who are in the pediatric age group who have been treated with horse ATG with eltrombopag triple IST, and currently they are on follow-up with us. So our own data is still in the maturing age group, maturing stage. Yeah. In pediatric population, eltrombopag gave mixed results and requires careful consideration. It has shown good safety profile and without excessive toxic effects. Addition of eltrombopag was well tolerated, and we have seen satisfactory hematological responses at 6 and 12 months. In the Escalate study, overall response rate to eltrombopag was encouraging. And eltrombopag combined with standard IST increased the complete response rate in treatment-naive children and increased overall response in pediatric patients with severe aplastic anemia, but not in those with very severe aplastic anemia. So what was the negative factors here? The trend towards relapse was higher. The event-free survival was significantly lower in very severe aplastic anemia patients who received eltrombopag compared to IST alone. Okay, so pediatric amendment of BSH management of aplastic anemia. So the algorithm is you have to first establish the diagnosis, and being a pediatric age group, we have to exclude inherited bone marrow failure syndrome, which may have overlapping features at presentation. And then we must do HLA typing with the family and the patient. So the first choice is going to be hands down matched sibling donor HSCT. But if it is not available, the donor is not available, then IST with ADGAM, cyclosporine or a 10 by 10 upfront murder if donor is available and criteria for upfront murder fulfilled. So if ADGAM is given prior to MUD, then assess the response to IST at 3-4 months. If there is no response, then we go to MUD HSCT. And if ADGAM fails and there is no MUD, then we proceed to the third choice, which is a mismatched unrelated donor. If no response to ADGAM and no MUD or MUD available, then the fourth choice, which is a clinical trial. And if the clinical trial is not available, then we may offer them another course of immunosuppressive therapy or androgens or alemtuzumab, eltrombopag. And the fifth one here is a haploidentical transplant. So in the absence of matched sibling donor, immunosuppressive therapy with horse ATG can be considered as a frontline therapy. So in this is an Indian experience with immunosuppressive therapy and horse ATG. These are all the retrospective type of studies performed in the pediatric population. And so our own thymogam was used in almost half of these studies. And the outcome has consistently been above 50% except for one study. Okay. So the response rate of thymogam in adults is similar to that of ADGAM from India. ADGAM is the innovator molecule from India and elsewhere, with ADGAM being 3 times costlier than thymogam. So it seems to be a viable alternative, and I agree to that 100%. We have had similar results with thymogam, and at I think almost 1/5 of the cost of the ADGAM. So we are lucky to use Thymogam here. This is a single center experience from India where they have published their results of immunosuppressive therapy for aplastic anemia patients. And they've analyzed around 90 patients, out of which mostly they were severe category. They received indigenous preparation, that is the Thymogam, with cyclosporine. And the dose was the standard 40 mg per kg per day for 4 days. And three patients received at a lesser dose was given. Cyclosporin was kept at the dose of 10 mg per kg along with horse ATG and continued until the patient became transfusion independent or for a minimum of 1 year with periodic monitoring of blood levels. And the responses were analyzed separately for pediatric and adult population, survival, and adverse events. So we can see that at 2 years, at the final follow-up of 24 months, 62, that is 68%, nearly 70% of the patients were transfusion independent, which is very good. So, and clonal evaluation was was found only in two patients, and they had a mortality rate of 31%. But I would say in absence of transplant without thymogam, these patients would have had much, different picture. So the 68% success rate is soothing in this regard. So the horse ATG and cyclosporin aplastic anemia, this is a study published from PGI India, and we can see at 3 months, although the response was not that robust, but if we look at the overall response at 3 months, which is 58%, and at 6 months, which is 77%, which is matching with the ADGAM studies as well. So we can safely say that the thymogam is equal and maybe better with its cost effectiveness for the treatment of severe aplastic anemia patients. Again, this is a retrospective study of 60 patients from southern India, where they had response rates in the to the tune of 70%, to the tune of 68.3% in at 6 months, and there were no relapses or clonal evaluation in this particular study period. Okay. And with the use of hematopoietic growth factors, there was no difference in overall hematologic response. So, and we don't have a routine practice of using hematopoietic growth factors at our institute in absence of any frank neutropenic sepsis, because the responses are not well documented, and if at all, they're short lasting and they may prove to be uh, inflammatory as well to the patient. So, this is a review published in the Pediatric Hematology and Oncology Journal. How good is immunosuppressive therapy? So, in 43 children which were serially diagnosed with acquired aplastic anemia and treated with IST from January 2012 to 2017, who were for some or the other reason unable to proceed to the stem cell transplant, they were treated with the standard dose of horse ATG, and these are the results. So the complete response was seen in 21%, and 20 months median time to best response in the whole cohort. Complete response occurred nearly in 2 years' time. There was no difference in outcome related to severity, presence of PNH clone, higher absolute lymphocyte count, or different available brands of ATG. Okay. And the overall survival rate was around 63%. And we can see that on a retrospective subgroup analysis between the type of brand used for horse ATG between ADGAM and Thymogam, there's hardly any difference in the overall survival. Yeah. So with immunosuppressive therapy using eltrombopag-based ATG and CSA, response rates and overall survival of up to more than 85%. So matching rates can be seen as that of the stem cell transplant can be seen in the severe aplastic anemia patients. GCSF may reduce the episodes of infection in these children but fails to offer any survival advantage. So there is no overall survival advantage of giving hematopoietic growth factors in the treatment paradigm of severe plastics patients. So this is another publication from Indian Association of Pediatrics, IAP. The standard of care should follow in diagnosis and treatment. So the way to go is match sibling donor bone marrow transplant. There is no doubt about that. But many a times we don't have the liberty to go to match sibling donor bone marrow transplant. Then in such cases, IST can be combined and should be combined and not be used as a monotherapy. MUD can be used when at least one course of IST fails. So they recommend to consider MUD only after IST has failed. L-Trombopac data in pediatric age group is still maturing. Therefore, it cannot be recommended as a routine, is what they say. This was published in 2022. I'm sure there has been a stronger development after that. Romiplastim is being tried for stimulation of hematopoiesis, but because it does not have tri-lineage potential and there is no enough data, so it's not routinely recommended as of yet. More studies are needed, obviously, to explore the role of thrombopoietin receptor agonists for patients with aplastic anemia. So, EATG CSA EPAG, Indian experience. Addition of L-Trombopac to immunosuppressive therapy, that is horse ATG cyclosporin L-Trombopac, which is a tertiary care center experience published in the Indian Journal of Hematology and Blood Transfusion. Here, they have given a 75% of overall response rate in patients of acquired aplastic anemia, which were treated with the trio, and as compared to the which is comparable to the results given from the Western world, that is US, and even from the European countries. Median duration of diseases, a disease prior to ATG-based IST was 1 year. Additionally, L-Trombopac was able to overcome the delayed initiation of IST in AA patients. So this particular study also connotes 75% overall response rate, which is good. Okay. And is triple regimen, that is thymogram, cyclosporin, L-Trombopac. So there is another study of 11 patients with severe aplastic anemia, and their median time to platelet response was 8 weeks. Overall response was to the tune of 72%, and around 63% patients achieved platelet counts more than 20,000. And transferrin independence was seen in 45% of the patients. Total 3 patients achieved complete remission. So soothing data are coming. French guidelines on L-Trombopac usage. So they are recommending extensive bone marrow workup and screening to exclude any clonal evolution or inherited bone marrow failure before introduction of L-Trombopac. Yes, because L-Trombopac given for long term without monitoring can, in certain cases, lead to clonal evolution and chromosomal anomalies. So refractory or in relapse 6 months after the first course of horse ATG and eligible for HSCT, and ATG naive and unfit patients. So there were two cohorts how they used, and in patients who were refractory to all of these, the response evaluation was done at 3 months, and until if the response was not obtained, it was continued for up to 6 months in non-responders. At the end of 6 months, also, if there is no response in the recovery of the counts, then they have stopped L-Trombopac. If there is any response, then they have continued L-Trombopac even at 6 months. And if there is a robust response, then they have decreased L-Trombopac by 50% for 2 months, and then they have stopped. And they have done a bone marrow workup to formally exclude clonal evolution at 6 months and at 12 months basis under L-Trombopac, even when it was stopped, because we must monitor clonal evolution in younger patients, especially because they have the risk of secondary malignancies, MDS, and clonal evolution. So we must. This is something that we can borrow from the French. So the spring effect. Eltrombopag added immunosuppressive therapy consisting of ATG2 CSA serves as a springboard and leads to a faster and earlier recovery of the hematologic parameters. I don't think we have to discuss about COVID and aplastic anemia currently. This must be an older slide. Yeah. So choice of aplastic anemia therapy depends on the severity of the disease, how bad is the disease, how badly the patient is affected, the degree of HLA identity in a potentially related or unrelated bone marrow donor, and Also, we have to consider the funds availability in a given Indian patient. So the current standard first line immunosuppressive therapy is equine ATG combined with cyclosporin. And recently now we have learned the importance of eltrombopag with such a good improved response, and IST with EPAC recommended is the first line therapy, especially for non-severe patients or severe or very severe patients if they do not have a matched donor. And then they have tried adding multiple combinations of other drugs with no significant benefit, such as cyclophosphamide, mycophenolic mofetil, sirolimus, and substitution of ORCTG by rabbit ATG or alemtuzumab was equally ineffective because of inferior response rate, and not only that, just but there were excessive toxicities as well. Strategy of stem cell stimulation with eltrombopag in severe aplastic anemia is more successful than other approaches of intensifying immunosuppression, and longer term follow-up and different combinations and doses are needed to better define the role and optimal delivery of thrombopoietin receptor analogs for aplastic anemia in the future. And we must not forget that ATG should be administered in centers familiar with its use and to be given to admitted patients as well. Admitted patients only. Key takeaways from this exhaustive uh, webinar today is that horse ATG plus cyclosporine still remains the untouched current standard immunosuppressive regimen despite many efforts to improve beyond it. We have to accept it. Eltrombopag has shown significant activity as a single agent in treatment of refractory patients with response rate of 40 to 50%. And when it is combined with the horse ATG plus cyclosporine, the three drug regimen, the overall and complete responses were to the tune of 72 to 80%. And late events of relapse and clonal evolution are in accordance with the vast long-term experience with horse ATG plus cyclosporin alone. Longer follow-up will be important to determine durability of response, possible cure rates following the novel regimen, and also to monitor any other longer toxicities that we may otherwise not be able to monitor. So, Horsetage cyclosporine is the standard immunosuppressive therapy. Eltrombopag addition improves long-term survival in aplastic anemia at the standard recommended dosages. Patient can lead a transfusion-free life, and the treatment is well tolerated, requires only a brief hospitalization with proper monitoring for immunologic side effects. Thank you. Are there any questions from the audience? And thank you, Team BSV, for the wonderful opportunity and the wonderful topic, and for making the thymogram available for us. Yeah.
Thank you, ma'am. Thank you for this insightful session. There are some commonly asked questions. Shall we take up?
Yes, yes, ma'am.
Yeah.
Sure, sure.
Yeah. So there is a most commonly asked question is that how do you differentiate between aplastic anemia from hypoplastic MDS? What is the significance?
Yes. So, primarily, the presentation, the clinical presentation of both may be the same. Patients may come to the attention because of either one lineage cytopenia, which is predominant over the other two, or it can be a multilineage cytopenia. The difference comes in the pathological diagnosis, wherein the hypoplastic MDS will retain the features of dysplasia, and the normal lymphocytosis, relative lymphocytosis, which is well appreciated in the plastic anemia patients, may not be seen in hypoplastic MDS. Additionally, there can be a certain degree of fibrosis present in the hypoplastic MDS. And in such cases where we are suspecting hypoplastic MDS, older adults, varyingly hypocellular bone marrow, isolated areas of hematopoietic cells with dysplastic megakaryocytes with a degree of fibrosis or two. In such cases, we rely on NGS workup. And if as in the initial few slides we saw, there are certain genetic biomarkers which are predominantly seen in MDS related diseases, such as, say, DNMT3A or TET2 or ASXL1. If these genetic biomarkers are picked up on NGS, then the therapy then the disease is diagnosed as hypoplastic MDS. So we call them MDS defining genetic abnormalities. So morphological diagnosis and genetic diagnosis are needed to differentiate a hypoplastic MDS from a frank aplastic anemia patient, and it has profound impact on the selection of the treatment. Hence, in such cases, we must rule out one from the other. Yeah.
Oh, yeah, sure, ma'am. And another question is that what is the standard of care for very severe or severe aplastic anemia in elderly patient, and what is approximate dose that has you have seen as having a good response?
Okay. So, up to around say 69 to 70 years of age group, if the patient's physiological fitness is good, so because age is just a number, sometimes the patients who come to us in the 60 to 65 age group category, they do not have any comorbidities with them. In such patients, we have treated them with horse ATG, and in those cases, we institute a slow approach. We give the 40 mg per kg per day dose only, but sometimes we divide the dose into a longer schedule. So instead of a 4-day regime, we do it a 6-day regime, and we give the same dose so that we do not have any wastage of the vials, and the patient's tolerance is also better. But so far, I have not used less than 40 mg per kg per day dose in toto for any patient. And thankfully, there were no any ATG dose related mortalities or morbidities that we have witnessed in around 20 patients that we have treated in last 3-4 months with thymogram. So yes, so in elderly patient, the go-to approach is IST alone only. If they fail, like we have one patient right now with us who is around 63 years old, and she has completed 6 months of therapy from the first time she was given horse ATG, and she has shown no response. So that patient we have been counseling for the transplant, because thankfully she does not have any cardiac, renal, or liver problem to make a transplant contraindication, but financial implications are keeping her away from pursuing that option. But yes, to answer your question, we are not cutting down the dose, we are just giving it over a prolonged period of time. And yes, transplant can be advisable to up to 65 years of age group, but funds is a major limiting issue in areas where we work right now. Yeah.
Yeah, in continuation with the similar question, what are the significant unmet need that you feel they are still existing in treating severe aplastic anemia?
Okay, that's a good question. So the first and foremost unmet need that I come across many a times is during the diagnosis of the patient. Many of these patients are, they are being transfused from, their family physicians and other places without a formal diagnosis. They are initially mislabeled as iron deficiency anemia or vitamin B12 deficiency anemia, or because many a times these patients may have fever, so they are labeled as febrile thrombocytopenia or dengue-like fever with thrombocytopenia, and then they are inadvertently treated with steroids, transfusions. So delayed diagnosis is what we come across with. Then, because of the financial implications, we many a time cannot perform all the necessary blood tests, such as say PNH, which is the most significant test to perform in. But I'm being very honest with you right now. So academically speaking, we must do PNH for each and every patient. But the patients that we treat, sometimes they have hardly any funds for transfusion as well. So in such cases, it's very difficult for us to counsel them the need of you know doing the thorough workup or the comprehensive diagnostic workup. And the second problem that we come across is with compliance. Many patients, then when they feel better, they stop reporting themselves for regular follow-ups. And post ATG, we have to use irradiated blood products for obvious reasons. So availability of irradiated blood products is also an issue, because we receive patients from all across the Maharashtra, and only certain cities have access to irradiated blood. So then these patients have to travel a long distance for weekly transfusions until they achieve transfusion independency. So that is another issue that we come across. Yes.
So, ma'am, thank you, ma'am. Thank you for this insightful session. It was beautifully explained all the parts of the aplastic anemia and also the management as well as the guidelines. Thank you, ma'am. And also, I thank all the attendees for patient listening and being here with us for today's session. Thank you, everyone.
Thank you, ma'am. Thank you so much.